order. May I thank everybody for attending today, particularly our witnesses. I think this is going to be a big, comprehensive session, so we've got a lot to get through. There will be a lot of questions and a lot of answers. So may I extend a warm welcome to Chris Wormald, KCB, Permanent Secretary, Department of Health and Social Care. So Chris, you're very welcome. You have a long-term season ticket to this committee, I think.
I think this is number 75, scarily.
You must almost dream about us in your sleep, I think.
It's a pleasure, as always.
Hopefully you don't. He is joined on my left, his right, by Andy Brittain, the Director General for Finance Department of Health and Social Care. Welcome, Andy. On his right, Amanda Pritchard, Chief Executive Officer of NHS England. And on her right, Julian Kelly, Deputy Chief Executive and Chief Finance Officer. Welcome to both of you, and a particularly warm welcome to Antonia Williams, who is the Director of Public Spending for Treasury, and it's her first time before the committee, so you're especially welcome. Thank you very much indeed. Director of Public Services. Would you like to clarify your role? Because my piece of paper says Director of Public Spending, but just, Antonia, please, you tell us what your role is.
It is Director of Public Services.
Brilliant.
Thank you for the welcome, Chair.
Okay, well, I'm glad you've clarified that. Thank you very much. So let us, without any further ado, move on to our first question, which is from me. And let us come to you, Amanda Pritchard, if I may. And a very simple question. Why has it been so difficult for NHS systems to break even in recent years?
Thank you, Chair, and thank you for the opportunity to come and talk about NHS finances and no doubt more broader topics as well. So I think the backdrop of the place the NHS in is really important. So obviously, as the NAO report set out, COVID was a massive shock to the NHS, not just in relation to finance, but in so many other ways as well. What we have seen in the recent period since COVID is really a story of gradual recovery. So productivity, huge hit through COVID, bounced back very quickly, but obviously there is still a gap between where the productivity of the NHS was and is and where we were pre-COVID. So it is improving year on year, but we're not back to that level yet. Similarly, we've got huge efforts going on to recover elective backlog, and you can see progress being made, particularly around reducing long waiting times. We've got huge challenges with urgent emergency care. Again, you can see progress being made, particularly around things like reducing ambulance response times, which was the big focus from last year, which has been sustained into this year, but much further to go on all of those things. So for the financial position, and I'm sure Julian will want to say more about this, some of that then translates into what local leaders are grappling with within ICBs and within systems. So they've been trying to deal with not just that big kind of recovery challenge, but they've also been trying to manage the impacts of inflation, which we've had over the last few years, the impact of industrial action, which is now, of course, happily ended, at least for now. And they have been trying to do that in the context of what has in practice been, a task of really reducing those COVID costs out, such that they can focus their resources on doing what patients need now and planning for the future. The bigger backdrop to all of that remains, of course, and Lord Darcy was very clear about this in his report, the fact that for many colleagues, they're doing that without necessarily having the capital estate that particularly facilitates it. So we've talked before at this committee about backlog maintenance and the just day-to-day impact that has, for example, on being able to run efficient services, and the very welcome increase in capital funding that's just been announced sort of speaks directly to trying to address that, as does the investment that's been made in technology to try and get to a place where, again, we've got we're giving the NHS the best chance of being able to use its resources as effectively as possible to meet what are growing needs for our population. And that's just the last thing I would say is, of course, all of this is against a backdrop of ever increasing levels of demand, partly because we just have a growing and an ageing population with multiple conditions, and partly because, as I say, sort of coming right back to the impact of the pandemic, we have seen some of that pent-up demand, of course, now come through in recent times. But
okay, well, yes, I'm coming on to Mr. Kelly too. Thank you for that introduction, and we will be probing all of those areas, I think, that you mentioned, but thank you for covering that, as it were. Mr. Kelly, why do some integrated care boards overspend but others do not? Why is there such a difference in performance?
So I think several factors. They actually start in different places historically. So as the sort of tide of COVID has receded, I think we have seen some of the problems that existed before the pandemic re-emerge. Some have had more significant issues dealing with actually COVID and to some degree industrial action. And though we have seen some, as we have grown the substantive workforce, and I'd say successfully over the last few years, have not taken as prompt action to sort of take out the temporary staffing costs as others have. So I think, there's a variety of structural, historic, and in some cases, sort of absolute local leadership and management grip. And it's a combination of those factors in different places.
That's helpful. So, either of you, what activities did the NHS England cut in order to reduce spending against central budgets and bailout systems 22.3 and 23.4?
Sorry, I didn't quite catch the question. My apologies, Chair.
So, what activities did NHS England cut in order to reduce spending against central budgets and bailout systems in 22.3 and 23.4?
So, in 22-23, I mean, in some cases it was we were, not spending as much as we thought we were going to essentially on certain things, and we might have sort of recycled that in investment in order to do more, but because places were overspending, then we couldn't. We had to put it to covering those deficits. Going into 23-24 and 24-25, we would have had ambitions to invest more in increasing mental health capacity, supporting community services, doing more on technology. Now, we have still managed to make progress on those investments, but we have not done it at the scale and pace that we originally thought and envisaged. Now, the one thing I would say underlying the last 3 years in particular is inflation has turned out to be much higher than was forecast at the beginning of each of those years. So the basis on which we agreed budgets at the time with the department and the Treasury, based on whatever the sort of OBR's inflation forecast was at the time, in each of those 3 years, certainly 22, 23, 23, 24, and I think even in the sort of latest forecast for 24, 25, inflation has turned out to be much higher. Now that actually accounts for sort of an unfunded pressure of about £1.6 billion. That is, to some degree, not coincidentally, about the level of the sort of aggregate deficit the system's experienced in the outturn for 23-24.
Okay, thank you. And what is the expected final position of NHS systems against financial plans for 24-5? And will this again require NHSE to reduce spending against the central budget?
So, at the moment, our month 6 report to our board said that we were, and I will not get the precise number absolutely right, but we were about £650 million, or at least systems were about £650 million off plan. So worse than plan. By the way, that is about 0.7% of their spend. So in percentage terms, it's quite small, but clearly in cash terms, that is a big, number. That, by the way, is better than last year. So although it's not where we want it to be, it is better than last year, and you can see the progress people are making. At month 6, people are still forecasting to get back to plan. Now, we are working with every system across the country to see how close to those plans we can actually get. Now, I think there is a fair risk that we will not hit plan, though I think there is a fair chance that even at the end of month 7, we are still in a better place than we were last year. So, we will still work to get as close to plan as possible. I do not have an updated forecast to tell you precisely where between naught and a deficit will be, but systems are currently forecasting to get back to plan.
can you when you do know that
Yeah.
forecast, if you could let the committee have a note, we'd be very, very grateful. Now, blame it on me as a new chairman. I'm sorry, and you had a question at the top of the session. So let's rewind. I don't know who you're going to ask it to, and I bet you've got a question on medicine. So over to you. This is, I think, notified to you, Sir Chris, question on medicines at the top of the session. Anna Dixon.
Thank you, Chair, and good afternoon. Before I get into my question, I do just need to declare interests, including that I previously worked as a civil servant in the Department of Health and Social Care. I'm currently chair of a charity called Help Force, which promotes the use of volunteers in the NHS, and I have family members who worked for the NHS. So my topical question for this afternoon is that I've had various constituents who've written to me expressing their difficulties in accessing essential medicines. So Julie from Menston struggles to get her HRT medication. Other constituents are desperate because they can't get ADHD medicine either for themselves as adults or for their children. And Doreen couldn't get reliable supplies of Creon, and she has an enzyme disorder. So huge impacts for each of these on their quality of life. I understand from data, according to the NHS Business Services Authority, that nationally the proportion of HRT items affected by shortages has increased sixfold in the last year. So I wonder, I don't know if it's a question for Chris or for Amanda, if you could update us on what actions you are taking to secure reliable access to essential medications such as these.
Yeah, so I'll answer and then Amanda can add if she wants to from the NHS perspective. So as your question suggests, at any one time we are, for a variety of reasons, short of an ideal position on a number of essential drugs. The NHS uses thousands of drugs a year, and we are susceptible to a whole range of shocks to that system, normally manufacturing problems, and in some of the cases that you quote, that is the root cause, and these are world markets that work by supply and demand as usual, and when there are world shocks, we have to deal with the consequences. First thing to say is, of course, that is very, very distressing for the individuals affected, and our answers tend to be at the level of what we do at the macro, but we, as your question suggested, we always have to remember that there are individuals at the end of this challenge, and our message to individuals is always go and talk to your clinician, who can discuss your individual circumstances and what is best to be done. What do we do in that situation? We have a series of protocols that we work with our NHS colleagues about what we do about it, and there is no one silver bullet. We seek to secure extra supply where that is available, including in some cases paying a higher price for that. We seek to ensure that the supply we do have is used where it can have most impact with the people on whom the challenges are greatest. We look for alternatives. We have a series of clinical panels that we run with the NHS to recommend alternatives, treatments where the original treatment is not available, and that is the case in some of the cases you described, and we then look for, are there other mitigations? So which can be agreeing with the medical regulators and the manufacturers that stock is in date for longer. You may remember we had a lot of challenges with EpiPens, where that was part of the solution, or things like the different dosages may be used, that dosages usually available for children are available for adults, so a whole series of things. And we seek to attack the problem from all those different perspectives and seek to mitigate the effects until we can get to a position where supply equals demand again globally. Yeah, we also say it's normally a manufacturing or distribution problem being being sorted. So that's what we do in the general. We can write to you on any of the individual cases that you there, but it'll be a mixture of those techniques. Do you want to say anything about what the NHS does?
I think, Chris, I think you've done a really
I was going to say that we've got a lot to cover, and the only thing I would add to your replies, Chris, that some of the examples that Anna Dix has mentioned actually are dangerous if you run out. And so I think that...
data, if we could get data chair to follow up just to say how significant these shortages, how frequent they are, would be useful.
As I say, it's the fact that they are dangerous is why the most important thing is people discuss the situation and their individual circumstances with their clinician, because obviously that's not something we can deal with at government level.
Thank you very much. Chris Kane.
Yes, thank you, Chair. Can I talk to paragraph 10 in the report, which is talking about COVID-19 and funding in relation to that? I suppose it's a general question for Amanda and Julian, a big one at that, I'll grant you. How well would the NHS cope financially in the event of another pandemic?
Sorry, who was that
And
to?
that's to either Amanda or Julian or both.
Do you want me to, shall I? I'm happy to start. I'm sure Julian will want to come in. So I think it is worth saying that the government were very clear at the previous pandemic that the NHS would have the funding it needed to respond to the pandemic. And in the main, that was absolutely the case. So there were not the usual processes around setting budgets that we are now back into. And there was a move made which was much more about sort of estimating what I guess was sort of moving at huge pace we thought things would cost. And then sort of setting appropriate joint processes between Treasury, NHS England, the department, then to make sure there was a rapid sign-off to access those funds as needed. But it did mean that there was an awful lot more funding available for the particularly year sort of 2021 than there, or 1920, 2021, so that period to deal with the pressures of COVID. And part of what we did was suspend some of the normal financial rules at that time for the NHS to just reflect the fact that it was a need for everybody to do the most unbelievably extraordinary things in response to a brand new global pandemic. And the last thing that I think anybody wanted in the country was for lots of process to delay that. That is a little bit, though, what we've been working for the last few years to try and then put back some of those processes and some of the appropriate checks and balances and good governance around that. So the answer to the question what would happen next time is a bit dependent on what the arrangements would be next time, what the nature of a pandemic would be, what the nature of the financial arrangements would be. Some of the same constraints, though, I think, so Chris and I have both been at the COVID inquiry recently discussing this. Some of the same constraints that we had going into the last pandemic, clearly we still have. So the state of the estate, the pressure on our workforce, because we don't have a lot of headroom in the NHS at the moment. We're currently, occupancy levels are sort of 95% of our inpatient adult bed base at the moment, and similarly pressures on intensive care, both adults and children, remain. So I would say it probably would be less about funding that would be if what we saw, which by the way the absolute thing we can be certain of is it won't be the same as happened last time, but if we did see the same again and the same financial arrangements were in place, I don't think we'd be worried about the money, but we would be worried about a lot of the same things we were worried about last time around our resilience, our capacity, our ability of our workload our workforce to step up again to deal with something as challenging as last time. But equally, we've learned a huge amount since COVID, and we have a lot now that we didn't have, which would enable us to be more resilient. Everything from remote monitoring and the ability to treat people more effectively in their own homes through to really, I think now, much more tried and tested EPR processes to help us respond in an emergency.
Yeah, the only thing I'd add is it's very, very dependent upon what type of pandemic. So the previous pandemic to COVID, HIV, nothing like the same financial pressures, partly because of the timescale it plays out on, but partly for very bad reasons. There were no tests to buy, there was no vaccine to buy, There is no PPE that helps you. So there is a big thing about what sort of pandemic are you in, and what sort of financial pressure does that therefore put on your health and care system.
So I think this committee will be returning to the whole subject of pandemic preparedness, particularly after the lessons learned from the COVID inquiry. So if you're happy, Chris, we move on to Anna Dixon. Thank you.
Thank you, Chair. So if I could just ask the witnesses to refer to figure 10 in the NEO report, which shows a sort of historical data for healthcare productivity. So it shows very clearly that over the period from 96-97 right up until pre-pandemic 2018-19, I think the average across that period was about 0.6%, and sometimes a couple of percentage points up and sometimes a couple of percentage points down. Obviously, we've had the pandemic, so the sort of very exceptional bars at the right-hand side. But I wondered if, Amanda, you could speak, first of all, to really explain why NHS productivity continues to be sort of so much lower compared to before the pandemic.
Well, as I say, actually what we've seen, and this chart I think illustrates it really well, was this very significant drop and then this sort of very significant bounce back. Since then, what we haven't had is a sort of official ONS statistics that allow us to say definitively these are the numbers. What we have been doing, though, is obviously developing, I think, a pretty robust internal analysis of productivity to help us track, as well as paying attention, as you'd expect, to people like the IFS who produce their own reports, all of which are saying the same broad thing, which is that productivity it continues to improve in the NHS, and in fact it's improved a lot faster than we were doing pre-COVID. So this year I think we're about to officially tell the board this next week, we're running about 1.8% improvement this year. And that is, as you say, against a historic rate of somewhere around sort of 0.6, 0.9%, so, at least double what we were doing pre-pandemic. Now, that is a combination of, I have to say, a lot of things that colleagues are doing on the front line, which are really tough. And that is everything from seeing now significantly more patients, and the IFS pointed to this in their report last week, not just than last year, but than pre-pandemic, and doing so whilst particularly paying attention to reducing agency costs. So we'll have reduced agency costs by about £1 billion over the last 2 years. It's now running about 2.5%. So I think that's probably, Julian will correct me, but pretty much a historic low for the NHS. So doing that combination of more activity with really bearing down particularly on agency staffing, as well as, it bears slightly to the conversation we've just been having, but really we can see people are really leaning into the opportunities with things like biosimilars and generic drugs and using supply chain now really effectively. All of those things are contributing to actually our ability at the moment to run at a higher level of annual improvement. Now, we've still got, which I think is the final bit of your question, further to go to get back to where we were pre-pandemic. There are some things which are going to be really difficult to shift. And that is partly because some of the gap is accounted for now by things that are either driven by COVID or driven by other broader changes in society, which I think is worth just calling out. So the fact that we have this more complicated, older population means we are seeing length of stay increased from pre-COVID periods, and that doesn't look like that's changing anytime soon. Some of that is just acuity and complexity. I have to say some of it is also just the pressure on social care. So we can see that the difficulty in getting people discharged contributes to that. Second thing it's worth saying is, despite the fact that sickness levels have reduced from the peak quite significantly, and they're about 1% down now and consistently down, nonetheless, staff sickness is higher than it was pre-pandemic, and that is, if you look at the sort of single biggest cause of ill health in the NHS, it's mental health, depression, anxiety, some of which is definitely correlated with COVID experience. So those are two examples. A third thing that's just worth calling out is we have now got more robust infection control processes in place in hospitals in particular. For example, you wouldn't put a non-COVID, I think this is called out in the report, a patient without COVID in the next bed to somebody with COVID, because clearly, that would put them at risk. So a whole combination of things which look like they are more intractable in terms of a productivity challenge. Final thing I'll say, I'm sure Julian will want to come in, is the thing we are really conscious of in these figures, and honestly it's not to try in any way and to suggest that we're not bearing down particularly on acute productivity, which is what this points to, is that it doesn't really capture the productivity of the system as a whole. Yeah. So what we have done, particularly over the last couple of years, is really try and invest in out-of-hospital care. Mm-hmm. So things like virtual wards. We've now got 12,500 virtual wards in the NHS. So those are a really important piece of our now capability in looking after people effectively, safely in their own homes rather than in hospital, but we can't count that in our productivity measures. And that's just one example of a number of things where I think we are conscious that there is work to do, again, as the NAO says, in making sure that we have got a way of capturing productivity that really does do justice, not just to the acute part of it, but to everything else as well.
So just to clarify, they're not captured currently in your productivity measures, even the ones you're using internally. So obviously one of the crude things, you mentioned there about the limitations of measures of productivity. The other is obviously it's very sensitive to pay. So are you anticipating that with pay rises that productivity is going to fall? And I suppose linked to that, and some of the points you yourself have made that about social care interdependencies, and I'm sure we'll separately come on to the workforce. These sort of projections, both in the long-term workforce plan, which suggest 1.5% to 2% productivity improvements, how are you going to secure those? I don't know, maybe that is a question for Julian.
So we think they're absolutely possible to do over the next couple of years, because we still think there is further recovery to do. I mean, it's worth clocking that this is the first year, really, that we have not had some major enduring ongoing disruption. In 22-23 we had more people in hospital with COVID than we did in the previous 2 years, and last year we clearly had significant industrial action. So in one sense, this is the first stable year that we've had. So we still think there's further recovery to be done. The possibility of technology-enabled change, I think we're in a different position to where we have been in any of the last 10 or 20 years. I mean, I'll just give one example. Actually, there was a publication last week of some work we have done with in London, looking at a large-scale trial of the use of a thing called ambient documentation, which basically uses these sort of large language models to record conversations, turn it into medical notes, discharge letters, and the evidence is transformative. If you are a GP, it means you can be talking to a patient face to face without having to be tapping at the keyboard. It improves the use of your time in the appointment and saves material time after, in terms of you having to do medical notes and letters. So there are things that are possible to do now that weren't. And if we can get the right plan, the right investment consistently delivered, we honestly think we can, materially improve and an improvement in productivity.
If I may just challenge a little bit further, having sort of been around the NHS for some of those last 20 years, the promises of technology to deliver productivity improvement, have been there. I believe the NHS is still the largest user of fax machines. We haven't even adopted the technology that we've all been using every day for many of those last 2 decades. So I suppose it's really like, have you got well-developed plans that are really clear about how the adoption of these technologies is actually going to deliver on these? I mean, I suppose it's like, are you being an optimist or a fantasist?
You need to remain an optimist. But you need to go at planning, with some pretty critical sort of realism. And we have been rolling out the adoption of electronic patient records at a scale we have not achieved before, with the aim that pretty much by the end of March 26, every provider in the country will have one. We know the evidence is that those providers who have them and have implemented them well have a productivity which is about 13% better than those who haven't had them. You know, that is the evidence. We have our first national programme to roll those out and implement them. That is well underway. You know, that gives you the critical building blocks. The kind of promise of some of the things that technology can do that people have been talking about for 20, 30 years are now at the point where they're not just in sort of research and development, we are sort of in actual delivery. I mean, I just said we have done a large-scale trial of the use of ambient documentation. We can see where it will work. We know, and we have just done a massive investment in technology in primary care, which we think is yielding results now. The public polling we do, it's only on like wave 3 over the last 3 months, shows we are seeing improved public experience, patient experience with GPs. This is where you want it to be now. So we know these things can make a difference. We can see the signs of success where we go at it with a concerted plan over time. The trick will be, it'll be all through the conversations we have with the Treasury, no doubt, over the SR, is getting the kind of right investment that we can consistently apply over a number of years.
Thank you very much, Anna. Peter Fortune.
Thank you very much, Mr. Chairman. Just following up on some of those figures, and I'm looking forward to when you release the figures about productivity. You think that's imminent, do you? I think you said you were giving it to the board next week. I think
we will do an update on where we are.
Okay, yeah. Because I appreciate it's very difficult because of COVID over the last few years to assess these things linearly. So I went back to an IFS report from November 23, which looked at staffing versus treatment volumes. So it's comparing 2019 with 2023. So I hope it misses that sort of heat of COVID. And the comparison from then to now is 25% more junior doctors, 20% more nurses, essentially 20% more clinical staff, 16% more consultants. But in terms of treatment for emergency admissions, it's down 4.3%. Looking at non-emergency, it's down 1.3%. Outpatient appointments up 1.8%, and treatments from the waiting list up 0.8%. So it's pretty flat at that point, but with all the extra staff. So I guess the question is, with the injection that's coming up, what will be done differently? What will be done differently now to what was happening in 2019?
Look, clearly for where we are today, we are seeing non-elective volumes above where we were pre-pandemic. We are currently doing 15% or more elective activity than we were doing pre-pandemic. If you look overall at the NHS, by which I include mental health trusts, community trusts, GPs, it is still true we have a gap. We have about 19%. So I think we've actually got about 19% more staff in aggregate, and we are currently seeing about 14% more patients than we were pre-pandemic. So there's still a gap to recover.
So what was that number again, more patients? Sorry, I missed it.
About 14. That gap has significantly closed, and as the IFS recognised in their recent report, they can see that sort of rebound and recovery playing out over the last 6 and 7 months. And in November 23, clearly, we're also in the middle of industrial action, which has... So, as we've just described, we are seeing further recovery for the NHS overall. It's about 19% more staff, we're seeing about 14% more patients. There is still further to go. There is still, some further recovery to be done, which I think is what we are anticipating over the next couple of years.
Yeah, if I could just add two points. One is when we look across the OECD, demand for health across goes up about 4% a year. So in some ways, the level of increases in staff numbers that you were quoting is not unusual, given that demand growth. And secondly, it's had one mention already, but the Darcy report is very relevant here in that it sets out the challenges of the NHS, including on productivity as being multi-causal. And he's very, very clear that there are a whole series of external things. There's COVID, there's a whole lot of internal things. There's a lot about the 2012 Act. And there's a lot about technology and there's a lot about investment. And we think he's completely right, and that therefore there is no one answer. So as Julian has set out, there is a lot to do to get the productivity levels that we want, but it's not going to be one thing that we can do. It will have to, just as the cause is multi-causal, our solutions will have to be multi-causal as well.
Thank you very much. Clive Betts. Oh, no, Luke Charters for a quick one.
Quick fire, perhaps for Ms Pritchard. Do you think there's a materially significant impact of staff mental health and staff burnout when it comes to NHS productivity?
Yeah, I mean that's as I said a moment ago, that's the sort of single biggest reason why staff are off sick, and sickness rates are clearly play into our bigger picture around, well, not just productivity, but actually much more than that, because that's about quality of patient care. It's about, the ability to recover on a whole range of other things. So we are, as part of last year's long-term workforce plan, we're looking not just at training and bringing in the right number of staff that we're going to need for the future, and we're not just looking at the skills that those staff will need. The big pillar of that was under the term retention, but that was a whole range of different things, which were everything from actually we're doing a review now around occupational health services and what the best sort of local support looks like to try and make sure that we're providing the best possible advice to the NHS about what the best organisations are doing and how to roll that out locally. So everything from that through to a bundle of measures that have been proven to work that will enable people to have the kind of work-life balance that means they can generally sort of stay well, stay at work, really participate and see flourishing careers, which would include things like flexible working. So there's a whole range of things that we can see are collectively helping to bring, as I say, sickness rates are down by about a percentage point, retention rates are have gone the right way. We've seen improved feedback in the staff survey, but there is much further to go on all of those things.
Right, if we're not all going to be here till midnight, we're going to need short answers and short questions. And an example of that is now going to come from Clive Betts.
Thank you very much, Chair. First of all, to Amanda Pritchard and Julian Kelly, the NHS is a very centralised organisation, and the various parts tend to respond to central direction. So are you responsible for the maintenance backlog that's now developed?
So it's an interesting point, because I think the NHS is an extraordinarily decentralised organisation. If you look at the number of different organisations with their own boards, and then think about, as you well know, of course, primary care, mostly independently provided, 6,500 GP practices. So we do have a range of things that, as national bodies, we can do to try and provide direction to the NHS. Set standards through the mandate that comes from government and translation into planning guidance. We have various statutory and other levers, but actually ultimately the NHS is and rightly run very much by local leaders as part of their own structures, now collaborating through ICBs. So part of that structure means it is for local organisations to make sure that they are on top of their maintenance requirements, their maintenance backlogs, and that they're then distributing, making decisions about capital in a way that balances the need locally, both to absolutely to meet particularly the sort of critical high-risk backlog, but also to invest in developing new capacity and expanding where they want to. The thing that they do have to do, which again my colleagues might want to talk to at the moment, is live within the capital allocation that does come from government. So that process of then making the decisions locally about how you choose to spend it is where the sort of national overweight...
Well, I'll just go on to that in a second, but it's... I don't think most organisations I talk to in the NHS would recognise that description of the amount of freedom they're supposed to have. Most of them say all the pressure is on, balance the budget by the end of the year, do whatever it takes, and if that means generally stop doing some maintenance because that's the easy way to do it here and now, that's what tends to happen. isn't it? How do you get out of that cycle? Maybe it's you to answer or Sir Chris. I don't know.
Well, I think I would start by saying, I mean, you're absolutely right. In a national health service, there is a national mandate which is translated through planning guidance to local systems. So what is true is that there are national expectations set around priorities and around budgets. So there is just as, you know, we all have to live within a reality of constraints. So that is also true for the NHS. But actually, in practice, there's more flexibility. Clearly, if you can balance your plans locally, financially, and deliver the things that are being
But that's not happening, is it?
by
Just
government.
look at the maintenance backlog. It's gone up to £11.6 billion. And don't just say it's all down to COVID, please, because it was 6.5 billion in 2018-19.
Well, you might want to take that from a capital perspective.
Do you want to just come in from the departmental perspective
Yes.
on that? So, given the sort of size and age of the NHS estate, it is inevitable that it's ageing and the maintenance backlog is going to increase. Lord Darcy's report made that absolutely clear. What are we doing about it? The autumn statement gave the department the biggest capital budget in real terms since 2010, that's with £1 billion specifically announced for backlog maintenance and critical infrastructure risks such as RAC hospitals. So we are doing it. Investment is increasing, but given where we're coming from or where we've come from, it's going to take more than 1 year to fix it. The final point I'll make is when you have a capital budget, there is then, of course, a decision to be made about what's the best thing to do. Is it to take extremes? Is it to invest it all in the backlog maintenance budget, or is it to try and build some new facilities so you don't have to maintain those in the first place? And that's what we're working through right now.
Can we be assured then that the capital budget you get will now be spent on capital in future?
It will, yes, because the Chancellor has introduced new fiscal rules which prevent transfers from capital to resource funding in future, so that's immediately ended.
Yeah, there's one other very important thing in this. There's both the quantum of capital and the what's the time frame. So the other thing that the Chancellor set out in the budget was that there will be longer term capital budgets. That gives, whatever the quantum, individual trusts and other institutions a much better chance of being able to set a proper capital plan where they are making the right investments at the right period. In my opinion, having a long-term capital budget is at least as important as what the quantum is. So those are the two big changes we're making.
So how much capital we spent for revenue purposes this year?
For this current financial year, up until at the current point, we have proposed a switch of £900 million. That has come from technical things such as the ring-fence budget for leases. It's come from the new hospitals programme where delivery has been slower than anticipated. So we haven't proactively decided to stop or slow down programmes. That's where headroom has been.
But it's money that should have been spent on capital.
Yes, of course. Yeah. So in an ideal world, we would have done it. However, it was available for that reason. So that's why we've done it. But as I said, now it has ended. It will not happen in future.
So nothing from next financial year onwards.
That is what the Chancellor has said in her statement. Yes, that's the new fiscal rule.
Okay.
How is the capital hospital programme going? Because if you don't start to do, as Clive says, something about the inroads into the backlog, you're going to get to the situation that the committee saw in West Suffolk or in Huntingdon hospitals, where they are literally almost on the point of, the buildings are on the point of collapse. And how can people work in the NHS in those sort of conditions efficiently and productively? So this backlog does need to be addressed.
Yes, absolutely. So I've set out the action we're taking on the backlog. On the new hospitals programme, as the Secretary of State has set out, the new hospitals programme is currently under review to put it on a long-term, sustainable and deliverable footing. All of the schemes are being reviewed. Some are out of scope. So the ones that are out of scope of the review are the RAC hospitals and ones which are sort of had full business case approval and are in delivery. So they are not part of the review. We're just going to get on with those as quickly as possible. The ones that are in review will be looked at as part of the spending review and put on a sustainable and deliverable profile. That work's underway and will be set out in due course, the outcome of the review.
The examples you raised, Chairman, they're exactly right, and they're why being able to have a long-term capital strategy is part of the answer. So, there you are, you're running a hospital, you've got 1 year's capital and the kind of block you're describing. You have no choice but to prop it up. If you can have a 5-year proper capital strategy, you can decide, actually we're going to demolish that one, rebuild it in 3 years' time, and if we have that kind of level of certainty that Chancellor has promised, you ought to be able to get quite a lot of allocative efficiency out of being able to take, as it were, rational capital decisions at local level about how you manage your estate. That's why the long-term certainty bit is as much a part of the answer as the quantum.
Just one further question.
Right, so 900 million is going to be transferred from capital to revenue this year, but apparently in the first part of the year, the NHS estate had only spent 50% of its capital budget on capital projects. Doesn't look like it's going to spend the rest, is it, effectively and efficiently?
Mr. Kelly may wish to chip in on this one, but I mean, normally the way it works is that capital delivery increases as the year goes on, as people get contracts approved and signed, for example. So we normally see sort of a hockey stick approach where a large amount of it is delivered in the second half of the year. I think currently the NHS is planning to spend roughly approximately forecast.
It's yet another of the problems of having the money year by year, actually. Because obviously if you don't know what you're going to be spending in the following year, you wait for that year and sign contracts then, and you get that rather odd profile that you describe. So I think it's probably part of the same phenomenon. But
Right, can we just ask a simple question then? £900 million has been transferred. Will the rest of it spend on capital this year?
Yes, and the NHS is currently on track to spend pretty much all the capital that has been given to it.
So could Sir Chris or Julian, one of you, produce a note for the committee exactly where we are with this new hospital building programme?
Yes.
Because there are obviously colleagues that have got a huge interest in that. Yeah. Thank you very much indeed. Sarah Hall, please.
Thank you, Chair. I just want to start just by going briefly back, touching back on the temporary bank staffing and the extensive usage and the variation of usage. So I guess I want to know why is there such a variation in usage between the ICBs? And what do those gaps, what do those roles that need to be covered, what does that tell us about the types of vacancies that there are? What kind of length are they covering for? And is there is the department taking taking the chance to have a deeper understanding of why those roles are and what we need to do to fill those roles?
So, as Amanda set out, we have seen a really material reduction in the use of agency staffing over the last 18 months. And as we said, we're on track to reduce the total cost by over £1 billion over the last 2 years. And as a share of the kind of workforce, it's as low as it's been since we started measuring it. By the way, that is good, because we are recruiting substantive staff. We know that staff are happier, more efficient, to go to Anna's point earlier, when you have substantive staff. We think there is more that can be done in that area, both this year and in future years. And indeed, we would look to some of the kind of best practice where we have had trusts who have basically got rid of the use of agency staffing. But it does require you to get to a level of kind of substantive recruitment before you make that move. And we're in sort of discussion about, what is a sensible target set for next year and the year beyond. We know we have some specialties where we have particular issues, and I would say mental health nursing, where we have some of the highest use of agency staffing, and that will be because, in the previous decade, we did not train enough mental health nurses. So as you look at the kind of long-term workforce plan, a key issue is, are there particular specialties where we know we need to keep growing the substantive workforce, and until we have, we won't deal with all of the kind of, all of the temporary staffing issues. And then, clearly we are in discussion, because there is, as you said, variation between trusts, and it comes down to how good are you at managing your total workforce, how good are you at your rostering, what are your levels of sickness, absence. So it's identifying those where you have higher use of temporary staffing and really working with those trusts to understand why, what is it in their processes, systems, culture, that the things that they need to sort out to improve the position where they are more dependent on substantive staffing. But we are making real progress in this area.
So is that being prioritised? Because as we've both said, there are disparities.
No, I mean, it's clearly, we in the last 2 years have set caps on the total amount of agency spending we expect by provider. And I forget the precise percentage, but in the vast majority of cases, we are now, seeing people live within those limits, and we will continue to work with them, and we are working with trusts to identify where they can do better job planning, better rostering, where technology can help.
Right, I'd like to move on, if I may, to the foreseeable pressures in future of the NHS. And as we know, we've touched on again, the population is increasing and getting older, and that comes with that of obvious challenges for the NHS. So what actions are being taken to address that predicted rise in demand for health services?
I can start, and then the NHS colleagues can add. So, well, as I was saying before, this is not new. Since the creation of the NHS, demand has gone up by roughly 4% a year. Now, from our studies, only about a third of that is straight demography. Another third is technology, particularly new drugs to treat conditions we couldn't treat before, and about a third is policy, i.e. we ask the NHS to do more than it was previously. Now, when the chair will have heard my spiel before, when I used to talk about this pre-COVID, we then talked about GDP rose by about 2% across the same OECD countries, and the big challenge of Western health is how do you meet the gap between the 4 and the 2, and that's been a long-term equation, certainly for since the creation of the NHS. Now, to deal with it, you have to hit all three of the causes. We must be very clear what is it we are asking the NHS to do as a society, and is that top of our priorities list, and is it affordable? We need to reduce the burden of ill health, which is not really length of life. It's, as I'm sure many of the committee members know, is the number of years spent in ill health. And as we have lengthened life, we have lengthened the period people spend in ill health more, as it were. So we have to tackle the drivers of ill health. There is a vote on the smoking bill, I believe, tomorrow, which would be a huge step in doing that, but lots of other drivers of health around obesity, around activity, around air quality, so the whole public health agenda. That is clearly part of the answer about how you would bridge the gap between the 4 and the 2. We have to find those technologies that save money as well as cost money. It is, of course, wonderful that we create lots of new drugs to treat things that could never be treated before. That's a good thing, not a bad thing, but it comes at huge cost. So as Julian was describing, what are the technologies that save money? And we have to attack, therefore, that gap between economic growth and health demand from all those various perspectives, including, we've already covered productivity in quite some detail, and you're only going to make, and this is nothing to do with the NHS, this is the story of Western health, you're only going to make it long-term sustainable if we can use all those various measures basically to close that gap between the 4% and 2%, unless we are all just prepared to pay more. And it doesn't really
Chris, taking you to paragraph 4.1 or 4.10 on page 49, and Sarah Hall is absolutely right to press on this. If you look at the final bit of that paragraph, It says more widely, Health Foundation predicts the number of people diagnosed with major illnesses will be 9.3 million by 2040 compared with 6.7 million in 2019, an increase of 39% when the population is only increasing by 13.1%. So, I mean, how much are you in the department concentrating on these long-term trends? Because otherwise the health service is going to become completely unsustainable.
In exactly the way I've just described. So they, you will know this from all the hearings we've had, that the challenges of health are necessarily to speed. It really matters if we are delivering today for the patients of today and those ambulance queues and all those things. We can't say we're only going to focus on the long term because all those services today really, really matter. And likewise, exactly as you say, we can only maintain a health service that is sustainable. And I say it's got nothing to do with the NHS. Every country faces the same challenges if we are doing the long-term things that we're that I've been describing. And as I say, what we are, what you are voting on tomorrow in terms of smoke-free generation is exactly the kind of long-term reform we're going to have to make if we're going to deal with both the overall burden of health and, in the case of smoking, particularly the local variations and variabilities that it drives. So part of the challenge is on our side of the table to be efficient and productive, and part of it is on your side of the table to give us the legislative framework that allows us to tackle all these various challenges.
Thank you.
Is there anything you want to add?
I think we've got the flavour. Sarah Hall. Are you?
I think that's it for a moment. I have a pause.
Very good. Thank you very much.
Yes. Follow on if you
want
of
course.
To continue with prevention.
Yes, of course, please, Anna. Anna Dixon.
Have you got?
Yeah, that's fine. I'm going to go to expenditure otherwise. So.
But I think we'll get back to prevention, public health, and we need to come back to public health.
Fine. Great.
Maybe, Sarah, you want to come back to public health?
Yeah.
Okay. Question.
Yes, I'm happy to pick up. Anna. So this is really looking at sort of. So we've talked about productivity, really about whether the sort of total expenditure, but also allocative efficiency of where we're spending the money. So in Figure 2 in the NAO report, again, some historical data. We know that sort of long-run increase in expenditure, historically 3.6, probably nearer to 4, between sort of 2014 to 2018-19, it was between 2 and 2.9%. It's flatlined a bit recently, but obviously with good news in the recent budget, increasing the RDL, the day-to-day spending for the department, 22.6 billion over 2 years. I think is sort of taking you back up to around that 4% growth in expenditure. So I guess the question, we've heard a bit about demand and some of the things that you can do in the long run to try and reduce those demand pressures. But what sort of future funding increases do you think the NHS needs to keep pace with some of the rising future demands? And I suppose it is a question for you, Sir Chris, and then I guess we might come to the Treasury to say.
There's not a lot for me to say on this question. There are a whole series, as you know, there are a whole series of projections done by think tanks and others. Our responsibility as public officials is to spend with best value what it is the government and the taxpayer decides to invest in health. The department does not project future expenditure. That is set in spending reviews in discussion with our Treasury colleagues. And as I say, we focus on are we spending the resources that we do have as effectively as possible. We do, as I've just described, look at what the demands on health are. My 4% number is a demand number, not a cash number. And the challenge we set ourselves is how can we reduce that demand, both for the benefit of the taxpayer, but also for the benefit of individuals. because obviously if we are keeping people in good health, I don't know why I'm saying this to you, no, but if we are keeping,
may not.
Yes, if we are keeping people in good health, there is a double win. Those individuals obviously benefit, and the taxpayer also benefits, and we can then concentrate NHS resources on the people who really need it. So there is clearly a massive win in that demand space, which is why we're focused on it in the way that I described. But on the funding questions, those are settled in spending reviews in the usual way.
So in terms of the allocative efficiency of the money that you do have, obviously there's a number of things in this report that suggest that more of that money has gone towards the acute. So some of your central budgets that were cut seem to be relating to primary care. We know the public health grant, for example, has been cut by, I think, it's estimated about 20%. So are we, social care has, relative to the NHS, had a much poorer settlement historically, even with the uplift in the recent budget. So do you think that there are reasons to shift around the funding to deliver more for the same amount?
Yes, so the new government has set out 3 shifts that it wants to see, analog to digital, as you were pointing to before, from treatment to prevention and from acute to community. Now, at one level, so if you look around the world, those are not controversial ideas. Most health systems are trying to make those changes. The numbers you point to just show how hard that is, and it comes back to my 2-speed health service point. People, you would want to see those shifts over time, but not at the expense of patients now. Well, now, the pressures on the acute, and I'm sure Amanda can say more about this, have been intense, and those are real people who need their A&E services or their elective services or whatever, and governments have made their choices about prioritising those people. But over time, we will see exactly the shifts that you say that are set out in the government's 3 shifts. Do you want to say a bit more, Amanda, about what you're doing?
Yeah, sure. Thank you, Chris, because that's exactly, those 3 shifts, I think, are exactly the answer, certainly to the sort of a medium term. So you've rightly set out the kind of big existential questions about the very long term. So great that we now have a 10-year health plan opportunity to describe what that longer term future looks like. But in the medium term, and I've talked about some of it already, we've touched on all the things that we're trying to do to make the NHS as efficient as possible, some of which is definitely enabled by technology, but some of it is also enabled by this shift from hospital to community. So where the big investment has been actually, even over the last 2 years in capacity, it has been into community rather than into hospital. So we did put more beds in last year, more what's called core beds in last year to get up to about 100,000 beds in the NHS, which would only have had the impact that it had because at the same time we had this 10,000, now 12,500 virtual ward beds in people's homes in the community, supported by an infrastructure around single points of access, urgent community response. Because with the nature of, as we were discussing earlier, an ageing population, the only way I think that we believe that we are going to be able to provide the care that people need, the care that people want, is increasingly by looking to people's homes as the predominant place of provision. So that will require the shift that we've just described to be supported by some of that data and technology, which needs to be able to identify population risk, stratify those people who are most likely to need enhanced levels of care, linked with then the sort of frailty services that we've begun to invest in the NHS, supported by those urgent response services, such that rather than ever take an older person to hospital in the back of an ambulance if they don't need to go, if they need to, that must happen, but if they don't need to go, we can provide better care in their own homes. And I saw personally just a brilliant example of that up in Middlesbrough just last week. So that second shift, I think, is going in the context of our ageing population is crucial, and then prevention, yes, of course.
But isn't that going to require more funding in social care?
Yeah, I mean, you're absolutely right to say we can't ever really talk about health without talking about social care at the same time. Clearly, I'm only responsible for the NHS part of this, but where I think ICBs have already, I call it, Chris will want to say more about this, but have already made a very big difference. I would say, I mean, this is a culture point more than anything else, but over the last couple of years, certainly I have seen really collaborative activity at local level and people really trying to problem solve together, whether that is about intermediate care capacity or it's about single points of access that actually properly link up processes. Again, there's loads more to go, but it's interesting now if you were to ask, I think, a sort of snap poll of acute chief execs, you'd be surprised perhaps by how many of them would say if there were a spare pound, put it into social care rather than put it into an acute trust, because that interdependency is very well recognised.
Thank you, and certainly the NHS providers who submitted evidence to us definitely made that point. Can I make one final point on this?
Briefly.
I'll try and make a brief point, and I will invite them to make a brief response.
Indeed, a very brief point from one of you.
So, obviously you're right to say social care elsewhere, except Better Care Fund very much established to invest in that sort of prevention, early intervention across social care. And continuing healthcare, 6.5 billion estimated in 23-24, that's on your account. So what are you going to do to make sure that we are getting value for money by sort of what the NHS's role in this integration and spending across health and care?
Do you want to pick that up? As part of the bigger social care question? Yeah, okay, so the continuing healthcare assessment process, I mean, the rules are set nationally, they're, as you know, implemented locally. It is a very skilled process, but it's a very complex process. And I think we would be the first to recognise that actually as part of a broader review, it would be very sensible, I think, to think about how we are looking at both making best use of Better Care Fund, the structures around it, but also the content of what the money is spent on, and it would probably be sensible to look at continuing healthcare as part of that. The emphasis at the moment is very much on, again, what we see increasingly, which is much better system working locally, and people then really working together as part of the annual planning process to say, right, well, what is working, what do we need to back, where do we need to do more, and what is it? And I think this is always a harder thing, but where actually it might have been something that's been invested in for a period of time, but actually it isn't a value for money investment, and it's time to use that funding better elsewhere, and we are seeing some good examples of that locally.
Okay.
Right. Thank you, Anna Dixon. Over back to Sarah Hall to probe the important issue of preventative health, which we're all relying on.
Had a little break and now I'm back again. So the National Audit Office 2022 report on the introduction of ICSs noted that while 77% of senior ICS staff who were surveyed reported their organisations intended to invest in prevention, only 33% felt they had the capacity to do so at the time. So with that in mind, and using, Sir Chris, your two-speed approach, do you think that the Department of Health and Social Care has been striking the right balance between focusing on now, in today's pressures, and focusing on the long term?
It's an almost impossible question to answer.
But a man of your calibre, Sir Chris, will have no...
well, I was thinking to have a go at answers, Jeffrey, so fine. So, obviously there are two levels of prevention. There is primary prevention, which is often not a fiscal intervention. It's in the things like what we're doing around smoking. And then there's secondary prevention, frequently done out of NHS budgets. The individual advice GPs give, etc. So it is not as simple a question of which budget goes where, as it were. It is about how does a GP spend their time, what does an individual consultant advise a patient on what they should do about their condition, and all that. That's point one. Point two is overall as I said, the three shifts the government wants to achieve, one of them is from treatment to prevention. So over a period of time, we wish to see more focus on prevention. As I say, it's not always cash. The answer to everything is not always cash, particularly in the prevention space. So over time, we want to do that. And that's why, again, what is the time frame is very, very important. It's one of the reasons why we want a 10-year plan, because, I'll say, the pressures of today you have to deal with. A pound is a pound, it can only be spent once. If you need it in A&E for something urgent, that is where it will get spent. Over 10 years, as a part of the 10-year plan process, we can begin to look strategically at, do we want to change over time the balance of our investments. Now, as I say, that does not necessarily mean taking money out of one budget and putting it in another. It may be GPs changing the balance of their time between what they do on the prevention side and what they do on the treatment side. Likewise, not are we taking money out of hospitals, what is the role of the hospital? Is it reaching out into the community and doing prevention things, or is it treating the people who come in through the front door? So it is partly a balance of investment question, but probably more it's a what is the focus of all our professionals question over a 10-year period. And then the last thing to say is it's really hard. I mean, everyone has said for many, many years we should spend more on prevention and spend less on treatment. At an individual point where you have a person who is in need and needs treatment, of course the pressure is to spend on that. And it's a completely reasonable thing to do in that circumstance. And breaking yourself out of that cycle is really hard, and most health systems, well, all health systems struggle with it. I'm sure you will only be able to do it if you take that kind of 10-year time frame that I've spoken about in terms of cash. There is an awful lot we can do on prevention, which is to do with culture, attitude, and the legislative environment. That is not always about cash.
Do you think that's why there's been such a lack of progress? Because do you think that professionals necessarily take this prevention and the various...
Well, yeah.
Did it get seriously?
So it's an interesting one. So were the Chief Medical Officer here, his answers would be considerably more interesting than mine, because this is what he has spent his life studying. He would point out that actually we've had a series of prevention triumphs. The whole of vaccines, the whole of what our predecessors did around clean water and safe food and all the things that have caused people to live longer. He would point to the rapid reduction in the number of people who die from heart attacks and from strokes as all being successes of prevention. What that has done is it's created a whole new series of new problems, as you were pointing to in your earlier question about people living longer and living longer in ill health with completely different conditions, particularly cancer and dementia. And so what we've done, if you look over that long period, is we've had a whole series of prevention triumphs, actually, which have left us with a whole series of new prevention challenges that we now have to meet, that go with the demographic changes that we've all seen. So I'm not sure it's really, have we focused on prevention, because I'll say if you looked over 200 years, this is the great success of health. It's about, do we have the right things to tackle our new prevention challenges now, which are different from those ones that I've described, that our predecessors were actually really successful at tackling.
So taking that one step further in terms of tangible action then, what action will you take to allow integrated care systems to make progress on the key things that they were set up to do?
I think that one probably is for you, Amanda.
Thank you. So I think Chris has put it brilliantly, which is ICSs have sort of two big opportunities here. One is the partnership work on primary prevention, which is less about investment and more about joined up plans, and really the NHS playing a role often as a support role in delivery of that. And then the second point, which is the secondary prevention. Some of the secondary prevention that we do is sort of national schemes that are then implemented locally. And then some are very much more about sort of local need and responding to that. So in terms of the national schemes, I think it is worth just saying on vaccination, at the moment with this winter vaccination campaign, so that's flu, COVID and RSV, we are currently vaccinating more than 300 people a minute. So that's more than 300 jabs a minute are happening in the NHS. So that is a huge amount of local activity going on, and that's just across those three types of vaccinations. So I should have said, sorry, it's not necessarily people, it's jabs per minute, because of course someone might have 2 jabs at the same time. Things like the diabetes prevention programme, so 1.6 million referrals since it was set up in 2019, digital weight management, 360,000 referrals, on track to prevent 175,000 strokes or heart attacks by 28-29. So those sorts of schemes that are very much kind of nationally designed, if you like, but locally implemented, we are seeing a huge amount of activity, and as Chris says, with some real benefit. The other thing that, it's again a national local thing, is early diagnosis. So it's a slightly different point, because obviously this is less about prevention, but the earlier you identify a problem, the easier it is to treat, often with better outcomes. So things like our targeted lung health check programme is currently diagnosing about 200 cancers a month, and lung cancer is traditionally one of the ones that's often diagnosed very late. The lung health checks, the targeted lung health checks, are diagnosing 75% at an early stage and are disproportionately identifying people who are from the most deprived quintile. So schemes like that, again, it's a national scheme, but it's absolutely delivered and implemented locally, and that is where the local teams, because they know their populations, this is a great example of they know their geographies, so they're much better placed than we would ever be to identify where to base a service like that where it's going to have maximal effect. But all of that is just to sort of illustrate, I think, and pay tribute, I guess, to how much my colleagues are doing and how hard people are working to try and get that balance that Chris talked about right, which is very much, understanding there is a real need to do, some of the heavy lifting on financial position, on productivity, on recovery now. And what we can see certainly is a huge commitment to doing both the partnership work on primary prevention and delivering the secondary prevention schemes that we've got up and running.
Okay, fantastic. I think that's good for me. Thank
you. So both you, Sir Chris, and Ms Pritchard are both sort of waxing about the cash and everything else of prevention. But actually the public health grant's about 1/5 that it was 10 years ago. And considering how much money this could save the NHS and how it could save all the individual patients going through a lot of agony that they wouldn't necessarily need to go through, surely we should be paying much more attention to the public health grant. That's a choice. Previous governments took the choices that they took. They took them very transparently. As I say, as public officials, our job is to implement those decisions to best value, as it were. So, as I say, it didn't happen by accident. There were conscious choices about how to balance up pressures in the NHS against pressures on public health. And as I say, governments took the decisions that they took. But I think you can hear from the committee's frustration that we feel that prevention should be taken much, much more seriously. Now, on that subject, I'm going to bring in Anna Dixon to ask Antonia Williams about the Treasury's attitude to this.
Yes, hello, Antonia. So, as colleagues have said, the shift to prevention has been something that's been desired for a long time, but the challenges are always making that investment with some payoff in the further years in the future when the pressures are on them to balance their budget in years. So is there any flexibility that the Treasury could look at that would actually, changes in your rules, that would make it easier for your colleagues to be making those investments, not only in the short term, getting in year waiting times down, but actually making the investments that are going to see that shift in the health of the population over multiple years?
Yeah, sure. So, I mean, I would just start by saying, obviously, we've had the phase 1 of the spending review at autumn budget, which the Chancellor has used to kind of reset budgets in effect, and it has clearly kind of prioritised the NHS through that, with the additional 22 billion RDEL and additional 3.1 billion CDEL. What the opportunity, we will then have phase 2 of the SR in the spring, which the Chancellor's been clear will be a multi-year spending review, and we've talked about 5-year capital budgets, which is a real opportunity to look and plan over the longer term, but multi-year for RDEL as well. This is a conversation we have very actively and lively in the Treasury about how do you kind of encourage and support more of a shift to prevention and early intervention. We know that you can get better outcomes across a range of public services and better value for money, but it is incredibly hard to do when there are also significant pressures on the day-to-day priorities. So it's something that we talk a lot to other government departments and to external stakeholders about exactly how do you define preventative activity, and there's interesting kind of insights and recommendations from the committee on this. But it is very difficult to do, actually, when you look right across public services, all the different types of intervention. And so Chris has talked a bit about this, but for example, when somebody's seeing their GP and they advise them to stop smoking, exactly what do you capture as prevention? Or for example, someone has a hip operation, not something we would see as prevention in an NHS context, but actually could help somebody get back to work and be prevention very much on the inactivity and worklessness side of things. So I think the multi-year SR does give us an opportunity to look over multiple years at budgets and when the potential payoff comes through. But we do have a tough fiscal context. Investment can be part of the answer, but we also need to be looking at non-fiscal levers, regulatory levers and others. And the Chancellor made a number of tax commitments at budget around the soft drinks industry levy, alcohol duty, those increasing with CPI, but again should make an important contribution to the prevention agenda.
Rachel Gilmore.
I think you're all missing something. And I'm famously bad at maths. It took me 3 attempts to pass my O-level maths. But given that a pitiful 6% of the NHS budget is spent on primary care, are you at all surprised that prevention is somewhere further down the list than you'd want it to be? Because 10 minutes with your GP is probably the best sort of prevention you can do. But the budget just isn't allowing for that. You're spending huge amounts of money on hospitals, which is proof that prevention isn't working, and you're not putting the emphasis that you need to be putting on it, rather than putting the emphasis on more primary care, so our GPs can do the job that they're best at, which is convincing people to stop doing things that are bad for them, like smoking. I don't mind which one of you answers.
Who would like to answer that, Rachel?
I don't mind. I mean, it's for all of them, really. Just common sense.
Which of you would like to take that one? Amanda, this seems to be in your budget, so it's probably you or Julian, one or the other.
Look, I'm happy to start. I mean, I think, we've discussed some of this already, but clearly it has been a long-term intention to try and achieve a shift to community, a shift to prevention. This government's been really explicit about that, and I think it does mean that we've mentioned it already, but the process through the 10-year health plan is a really important one, to be able to crystallise what that ambition over a 10-year time frame would look like, and more importantly, perhaps even than that, how we would actually get there, because I think good intentions, as we've already discussed, often when they then come into that difficult potential trade-off between investing in things that will certainly deliver really obvious long-term benefit and meeting a today priority, it is very difficult for the government to make those sorts of decisions in a very short timescale. It is much easier when you're able to take a longer term view. And what we have seen over certainly sort of pre-pandemic periods was gradual increase, slow but steady increase in the funding that was going into mental health services, into community services, a big investment into primary care through the additional roles scheme, and now the training of GPs, additional GPs, that's now of course beginning to come to fruition. All of which put us in a place where I think we can say, we know if we can do something over the long term, we don't have a global pandemic to deal with in the middle of it, actually we do stand a reasonable chance of being able to build on some of these early foundations to get to a place where that is a much more sustainable model for the long term. So I don't think anybody would disagree. In fact, quite the opposite. We would all, I think, probably, although I don't speak for all my colleagues, strongly agree that those are the right shifts. But it's, I think, going to be a case now of really leaning into the 10-year plan opportunity to describe how we get there.
Thank you very much. Clive Betts.
Right, thanks, Chair. To Sir Chris and Andy Brittain to begin with, it's very clear, and everyone agrees, that getting bits of government to work better together is a better way to spend money and gets better value for the taxpayer and better outcomes. There's a feedback in the NO report that what's been said by some of the local government stakeholders in the process of developing the ICBs and working jointly at local level is that the objectives don't often lie. You've got the NHS, which is very centralised in terms of the requirements come down, and local government with a lot more local flexibility. I think often frustration in local government that they can't get the same rapport with their colleagues in the health service because of the restrictions on them. How are you going to address that?
Yeah, so I'll start and then I'll hand over to my NHS friends. I mean, the first thing is that's clearly right, and particularly between health and social care, trying to get integration between a service that answers nationally to national ministers and a service that answers to local councils, and one that is free at the point of delivery and one that is means tested to work together is really, really hard. Now, there's nothing that how many of us are there? The five of us can do about any of those things. They are built into the legislative framework, and we administer the legislative framework that we have, which is not to say that there is nothing that can be done to make things work better. And indeed, and I think Amanda mentioned this earlier, we have a lot of feedback from local authorities that while there are still lots and lots of problems, the working relations that are built into the ICS-ICB system, into BCF, and the local relations between NHS leaders and local authority leaders has actually been better over the last couple of years. There is a lot more to do, and it is quite variable across the country. And one of the things we get quite a lot of feedback to say, and I'm sure you see this in your own constituencies, is that when a trust is dealing with the local authorities it is used to dealing with, there are often very deep and very good relations, and you see the joint discharge teams in trusts and all those things. Many of our trusts deal with local authorities all over the country. So I was at one trust where it is only 25% of their elective patients who come from their local ICS. And when you are dealing with local authorities you have not dealt with before, you see a lot more problems, just intensely practical problems of not knowing systems. So we do think we've made some progress through ICBs and ICSs. We don't think it is by any means perfect. It's much too variable across the country, and we have that underlying challenge of the different geographies that a trust work on and a local authority work on. There is no way of equalising them, I'll say. So the trust I was talking to dealing with cancer, and its catchment area was the south of Birmingham to the south coast, as it were. And all the local authorities you have to deal with. There will be other trusts that have similar
Do you think you complicated that by setting up the ICBs when CCGs before very often, my own case in Sheffield, worked very well with the local authority, and right through COVID, brilliant working relationships.
Yeah.
Suddenly you've changed all the geography.
Yeah, and you're completely right. And there is no, for the reason I've said, there's no perfect geography for health. Some health questions are, at the level of the street. As I say, you take the trust I was talking about, it's dealing with half the country, as it were. There is no perfect arrangement. Now, CCGs, there were some brilliant ones. I don't happen to know the Sheffield ones, but they may well have been. And there was also a lot of them and they were quite variable. The previous government took the decision to go with the ICS model, and the current government has no plans to change that. We take the view that we work with the system we've got and make it as good as we can, as it were. And as I say, there is a lot of work going on. It is by no means perfect, and there is lots more to do, but we do think we've made some progress.
Could I follow up on a couple of other points then, in that case, Mr. Chris? You almost gave an impression before that you could do prevention without spending money. It was a cost-free zone.
Well, it's not always about cost. So there are obvious prevention things that just cost. So a vaccine programme has a cost. But
you mentioned clean water before. There's clearly quite a big cost in achieving that in the past.
Yes, no, that was significant.
Right. So let's come back to public health grants then.
So I want to be clear about what I'm saying. It is not all about cash. So a lot of those things which are about lifestyle, whether you smoke or not, to what you eat, all those sorts of things. They are about government action, and they're about government advice, and sometimes about legislation, but they're not always about money, was my point. I'm not trying to claim money is not important, it clearly is.
Right, so let's come back to public health. I mean, it's not your job, as you keep saying, to say how much should be spent, but do you accept that if the NHS is going to address prevention better and spend more on prevention, then cutting the public health grant is not the right way to do it?
Well, I'm not going to comment on previous government policy. They took the decision.
I'm asking about here and now.
Don't repeat what you've said in answer to my question. Is there anything else you want to add to that question?
So clearly, and this comes back to the long-term budgets that Antonia were talking about and the 10-year plan, we will want to look at over those longer periods, what is the right balance of investments? But as I said, it's also about what do professionals do, as well as do we move money between budget headings, as it were. So yes, we want to look at those questions, but over the time frames that I've described.
Right, okay. Well, I think we'll come back to that point at some future date, I'm sure. Just about Amanda Pritchard, just in terms of NHS England, it's important that you look at how your money is being spent and whether it could actually achieve better outcomes in terms of prevention. I'm just thinking we had a big issue which we discussed at very supportive from the ICB in South Yorkshire about child inoculations. And the way it's paid for, GPs get funded according to the number they achieve beyond a certain bar. That sends more money into the wealthier areas where GPs have got parents who are really willing to have them, and they get less money put into the deprived communities where GPs are really struggling to get inoculation levels up. Why don't you have a look at those sorts of things? Maybe targeting that funding better would actually achieve better outcomes.
Actually, if I pick that up, I mean, we think that is precisely like the issues you are looking for. Integrated care boards, working with primary care networks to identify. And we've got so many lessons to learn even from the COVID vaccine campaign of the kind of granular data of understanding where take-up is good and where it is not good, and what we learnt about how you reach populations who are not proactively coming forward. And by the way, to your point about local authorities and what we learnt about working with local authorities, most of whom probably have better links into some of those communities. And what we're looking for integrated care boards to do is precisely to identify where in their population that is true. Because if the jab is done, the GP will
Are you going to allow them
paid.
flexibility then in funding? Because currently they have to fund according to NHS remit.
No, they already have the flexibility, and if the jab is done, then the person will be paid, and they have the flexibility locally to work with their primary care networks to work out which are the less well-served populations and how do they reach groups who are not being, in this case, jabbed. And one of the things we are looking for is for them to show how they are doing that.
Okay, I might write you a note about that because I'm not totally convinced by the answer. We'll come back.
So I think I'm going to follow up with Mr. Betts' question. I mean, we're not just talking about jabs here. This is quite a narrow focus in your answer. It's the flexibility of the ICBs to determine for their local populations how they could best use their money in preventative healthcare. Isn't it, surely?
And they can determine how they use their funding. I mean, a very small proportion of the total funding we have provided.
Just said it's a small proportion of the total funding.
No, that we have provided on a ring-fence basis. So we have run certain, and we have funded specifically certain national programmes that we know the evidence says are some of the most cost-effective things that we can do to prevent long-term ill health, like the diabetes prevention programme. In that instance, it does not make sense, given we know what works and given we know the long-term health outcomes, to leave it up to every part of the country to decide shall we do it or not, and nor does it make sense to allow 42 different places to each buy the programme, because we know we have got better value by buying it once nationally. You know, it's like targeted lung health checks. We know they work. It is one of the big things we have done that has shifted the early cancer diagnosis rate when it has been stuck flat for the best part of the 10 previous years. And we have worked with ICBs to target it at those areas of the country with the biggest need. So I think it is that balance between when you know something works nationally, why reinvent the wheel, working out when it makes sense to sort of pay once and get the best value. That does not stop ICBs and local places using the many billions of pounds we otherwise give, which they are flexible, you know, where they have the flexibility to determine how it is spent and what services they are commissioning, still working out what are the particular local needs in their population and how are they commissioning services to tackle those needs. Now, when money is really tight, and it has been tight, witness the first questions you were asking, Chair, clearly the flexibility to pay for and commission new services is reasonably restricted. We have an obligation to live within the money that Parliament votes, ICBs, we seek to live within the budget. So when money is tight, the ability to commission new services is obviously tight, but they have flexibility as to which services they commission.
All right. Well, thank you for that answer. I'm sure it's something the committee will wish to consider and maybe we want to come back to, but thank you for the answer. Anna Dixon.
Hi, it's me again. So we talked a little bit about the short-term workforce, things you're doing on well-being and tackling agency. I'd like to shift to long-term workforce planning, if I may. So obviously securing a workforce over the medium to long term requires sort of balancing decisions about training new recruits, overseas recruitment, obviously investing in retention, maybe even persuading some people to return to work in the health service, and then also managing retirement and maybe persuading a few people to work for a bit longer. So could you just, given you have a long-term workforce plan, just say how confident you are in the current sort of data and plans that they are going to secure the right workforce for the long term? So I'm guessing this sits with Amanda and Julian.
I can start. Yeah, happy to start. So, no, thank you for that. So, I mean, I think it's worth saying that we do have, again, thanks to both a combination of international recruitment, improving retention rates, and some of the investment that previous governments have made in particular medical training. Now we've got 70,000 more staff now than we had pre-pandemic. So that has been a success story, and clearly keeping people then well and at work. So the discussion we were having about sickness, continuing all of the focus on retention, all really matters if we're then going to enable people to be able to live, you know, to do fulfilled careers at work. That, however, doesn't close the gap between the number of people that we need and the number of people we have, so we still have a very significant vacancy rate within the NHS. So the long-term workforce plan is crucial, and that is about, as I say, those three elements, but training, retaining, reforming being still the three pillars. I think the important commitment that we made at the time was that, given that, you know, looking out 15 years is crucial if you're going to try and train people, because it takes a really long time. But on the other hand, you know for a fact that whatever you say for a 15-year time horizon is going to need to change, because clearly an awful lot does change over that time period. We said at the time it was going to be really important that it was refreshed regularly, and we talked to this committee about that actually relatively recently. So this coming summer would be the first point at which it sort of hits an obvious opportunity to refresh and update the planning assumptions, and that ties in very well with the timing for the 10-year health plan. So I think we will want to take, we have the opportunity, we would want to take it anyway to make sure that we are updating the long-term workforce plan in light of the 10-year health plan, to make sure that that then is going to support the health service that we're designing for the future, and therefore some of the shifts we've discussed today, that shift to community, as well as some of the things that we spoke to in the previous plan, particularly the need to invest in primary care and continue to see a disproportionate growth in the number of GPs coming through versus other areas, and some of the existing gaps. I mean, Julian's already mentioned mental health nursing, so we would say that is still going to be the right balance between where have we got gaps now, and therefore we can see we're going to need to do more, but also where have we got opportunities with the 3 shifts and with the 10-year health plan, just to make sure we've updated the plan in light of that.
And will you update the cost assumptions when you do so?
I think, yeah, so our assumption at the moment is the modelling would be refreshed for this summer, and then I guess we'll have to sort of see what falls out of that. But I think we're all very conscious that we're still working within, this is not an opportunity to come back with a completely new plan. It's about refreshing the plan that we've already got, making sure we've got the balance right between the different elements of the plan and the different types of training that we were planning to invest in.
Yeah, and clearly there is this sort of not only increasing the higher education sector ability to train people, but obviously the NHS's own training capacity, and then the ability to actually hire the people we're training. So there seems to be some gap between the number of GPs coming out of training and the NHS's ability to actually employ them. So will all of those things be part of what you're looking at in the review of the long-term workforce plan?
Yeah, I mean, Julian might want to come in on this, but pace is a really important factor. So some things clearly we were very ambitious on, so increasing medical places was a good example. Other things were planned to be more slower starts and increase later. What we've got now is more data to go on, so we know, for example, that we had slightly fewer people who applied for nurse training this year than we've had in the peak of the pandemic. Lots of obvious reasons for that, but one of the assumptions that we made was based on the level of interest in joining these courses, and if the facts change, you have to update the plan in response to that.
Do you just sit? Hang on, Mr. Pritchard. Do you just sit there passively and say, "Well, there isn't a demand for nurses coming forward for training this year," or do you actually go out and stimulate demand in schools and so on? Because you can't just passively sit and hope that it'll happen. You have to do something about it.
Indeed, so hugely the latter. So we've run campaigns like We Are the NHS, which you will have seen, or I hope you will have seen, although to be fair, you're possibly not the target audience for it, so it's more social media led.
I'm a bit old for training, unfortunately.
We did speakers in schools last year, so I went back to my old school and talked to 1,000 people about careers in the NHS, but we've had literally thousands of people out in primary schools, in secondary schools, talking about careers, as well as all of the local activity that trusts do in partnership often with local schools, getting people in, encouraging people to think not just about...
Brilliant.
Oh, sorry, I'll stop.
Okay, all right, we've got to keep going. The time is rapidly running out. Rachel Gilmore.
So the first 2 questions about finance, I'm going to take them both together. I really appreciate brief answers, please. So where do you consider the value being in putting pressure upon finance professionals to agree plans that they know to be unrealistic, which are based on unachievable assumptions and savings? So I think that's probably one for Amanda and or Julian. And then what work have you done to simplify annual budgeting processes and to reduce the bureaucratic burden on finance directors?
So on the first, we have set out clearly in previous years, indeed for this year 24-25, both the money, what the expectations, what the ask is, what the rules are, It's a huge system. So we have had in-depth, detailed conversations with just about every provider and ICB and sort of as a whole system in the country. Boards are the ones who sign off the plan and say what they can do with the money that has been given and what their intentions are with respect to their workforce. And we personally met with every single system in the country, with all of the leaders, to confirm that over the course of May, that what they told us they were serious about doing. So I don't recognise some of the things that are said around financial fantasy plans. It's like you've given us a plan, you've signed it off at your board, we've discussed it in depth, we've agreed in some cases funding, extra funding to reflect the particular situation and specifics of individual providers and systems, and our expectation is if you as a board have signed it off, you are serious about doing it, and you have thought hard that the thing you have given to us you can do. And our expectation is as long as we honour the things we have said we will do, which we have done, that people do what they say they will do. And if they're off track, we meet with them to understand why and what they are doing to get back on track, or at least whether something has materially changed. And you can have things that materially change, and I will say the cyber attack in South East London does cause particular financial pressure and performance impact that wasn't in a plan, so we adjust.
So you're saying it's the boards that are fantasy planning?
No, I'm saying boards. I'm not saying anyone is necessarily fantasy planning. I'm saying if they have seriously sat down and said what they can do, and we look at it and examine it and challenge them on it, then they've agreed that's what they are going to do, and therefore we sort of sit down and hold them to account to follow it through.
Okay, now let's talk about the bureaucracy or the required lack of it. It should be the required lack of it. Sorry, I meant
so look, clearly, if you are handing over billions of billions of pounds of taxpayers' money to services, your expectation, witness this session, is that we can give a good account of what that money is being spent on and that it is delivering good value for money. Therefore, it's not that surprising if when we give money to people and the government sets out what its priorities are, that we're asking for an explanation of how that money is going to be spent and whether it's delivering the things that are consistent with the priorities we have been given through their mandate. We look to make that as simple a process as we can, but for something the size of the NHS, you are clearly going to ask for a reasonable amount of information back. So we seek to make that as streamlined as we can do. We have worked very hard on that over the last few years, and we will continue to. But I don't recognise it's entirely bureaucratic, because, as I said, if you're going to give billions of pounds, you are going to expect some explanation of what people are going to do.
So I don't want to put words into your mouth, but in brief, I think what you're saying is that bureaucracy is a necessary evil in the NHS.
Well, a certain amount of collecting data and understanding how money is being spent, and that people can prove that they're actually delivering stuff. I mean, that is inevitable. We seek to automate it, make it as simple as we possibly can.
Great. Moving on to question 12. So this is to Amanda and Chris. Why was there such delay in agreeing priorities in a final budget for NHSE for 24 to 25? Again, brief answer, please.
Sorry, can you repeat the question?
Why was there such delay in agreeing priorities in a final budget for NHSE from 2024 to 25?
Do you mean 23, 24?
No.
24, 25, it says.
Oh.
Could you remember?
There hasn't been a delay this year.
Well, no, we haven't done it yet.
Amanda, do you want to have Amanda Pritchard, do you want to have a go at that?
So I'm sure Chris will want to come in on this, because NHSE, our role is to translate, if you like, the mandate. Well, in fact, let's be really clear. There's a mandate that we get. We translate that into a document, which is then sent out to the NHS. We always try and get it out this side of Christmas, because clearly we would all recognise the need then, as per the conversation we're having, to get into a proper detailed planning process, and we want to give people the maximum amount of time to do it. But that process isn't something we can do unilaterally, so we would have a go at drafting and sharing planning guidance usually in November. That was certainly true last year as well, but it is a complex process of then agreement, not just between us and the Department of Health and Social Care, but actually with the Treasury as well. And in fact, I think I'm right in saying it goes for right round across the whole of government, because it's, as we're discussing, how this amount of public money is spent matters, and it's quite right that there is a process of kind of check and challenge as part of that. Chris might want to shed a light, I guess, on some of what was going on behind
we're running through time, and these answers are becoming...
Yeah, I'll just add one thing. So that year was particularly complicated because of the very high rate of inflation. That is both a problem in itself, and it also makes budgets very unpredictable. And there was a delay in that year, and there was quite a lot of reprioritisation that was going on, which was just a fact of a very high inflation shock caused not in this country.
Yeah. So I can take from what you're saying that the date you have all agreed on for releasing the 2025 to 26 planning guidance to NHS systems is not as delayed as the one for 24 and 25.
We would certainly hope not.
Okay, that's good. That was a quick answer. So do you accept that you should all agree, publicise and stick to a deadline for publishing planning guidance for future financial years as well?
Well, it depends on those external shocks. So, and to use your phrase from earlier, there is absolutely no point in going out early with a fantasy budget. So you do have a trade-off between how early do you do it and how certain are you about what the fiscal and economic situation will be. So if you are in the middle of an inflation shock, bluntly you want to do these things as late as possible. If you're in a basically stable position, then clearly you want to do it early, as it were. So I'm not going to give any guarantees, but that is how we would think about it. And in principle, you are, of course, right. The earlier you do this and the longer you give people to plan, the better, as long as you're giving them a realistic number.
So finally, to Julian and Amanda, so what are you doing to make sure that things are signed off in a more timely manner, well in advance of the financial year? Because to me, my background, very briefly, I worked for the Environment Agency, which I found really frustrating, but we would never consider starting a budget in November, the year before the financial year. And that was a big organisation with complicated needs, and we were subject to the same rigours, external rigours as you were. I can't get my head around the NHS doesn't start doing a budget until November.
We clearly try and give early informal indications of what people should be expecting, but we do actually need to know what is our budget in order to be able to give a budget. And if that process it doesn't conclude until October, November, or indeed in the case of 24-25 we were still in discussion with Antonia and colleagues on certain items up to the kind of March budget. It's hard to absolutely finalise it, but our aim is to give as much information and certainty as soon as we can. And clearly this year we still have some details to sort out with Antonia and the department, but we are aiming to do those as soon as we can, so that this side of Christmas, let's hope, we can give clear budget allocations and be clear about what the rules and framework is.
Okay, so you could do better 6 out of 10.
Well, we could always do better when we're complacent.
In our defence, so I mean, you're completely right. The reason it's difficult is because the number is so huge and the externalities are so great. So that huge element of the NHS, which is demand-led, how high is flu, how cold is the winter, is there a COVID spike, all those things which we can't know. And then a 1% variation on a budget of 170 billion is a size of move that interests our friends at the Treasury and affects how we manage the fiscal situation
Chris,
generally.
I'm going to cut you off there. I've heard all the excuses.
No, that was explanation. I was agreeing with the point.
I've heard the excuses.
Yeah.
But if you are trying to operate a ICB,
Yeah.
and you don't get your final settlement till June, 2 months after the end of the financial year, it must cause inefficiency in the way they operate. Let me ask you a very simple question.
Yeah.
For the 25-26 budget, when will you give the ICBs their final allocation?
We hope to do it as early as possible. Now, clearly doing it in June...
No, that's not an answer.
It is unfortunate. Given that I don't have a date, it's the only answer you're going to get. So, now, clearly doing it in June...
inefficient system is going to carry on then.
So, clearly doing it in June is suboptimal. As I say, giving out a fantasy number earlier because you have not worked through the inflation consequences... No, but you could do what Julian Kennedy is suggesting, give them an indicative figure which is hopefully as accurate as possible, so that they've at least got a realistic figure they can plan on from a much earlier stage. Yeah, I would say the crucial bit of your sentence, which I agree with, is realistic. Now, the question is, at what point can you give a realistic budget? And clearly, the greater the externalities and the more the variability, the later it is you can give a realistic number. I don't disagree with you at all. It's just those variabilities.
At least give me an aim of when you would like to get the money out to them in the 25.
Well, so ideally, as I think we've said already, we would do it before Christmas. Now, whether that is possible is not always entirely in our hands.
But if it gets later than that, do you agree that you should give them an indicative figure which hopefully is as accurate as possible?
As long as it is realistic, yes.
Yes.
If you can't be realistic, nobody else can.
Well, yeah. If and as I say, I'm simply being blunt with the committee. We have a series of externalities which and due to just the size of the budget, which makes our judgment on when is it realistic, that is a real judgment. Giving out an unrealistic number does more harm than good. So we will take a hard-edged view on when can we give a realistic, because as I say, I agreed with every single word of your sentence, Chair, when we will give and, as the questioner was saying, we need that to be as early as possible. I don't think there is any difference in intent here. I'm really saying if you get a price shock, if you get an energy shock, if you get any of these sorts of shocks, and then you multiply it. Sorry?
Risk analysis.
Well, so your risk analysis, so you take the energy shock, which largely dependent upon the actions of a foreign power. You can do a lot of risk analysis and you won't get to a number. As it were, nobody did.
I'm just going to say one more thing.
Yeah.
I think that from everything we've heard today, given the scenario behind the scenes and the difficulties that the NHS senior staff and junior staff have to work with, it is more and more exceptional, the job that they do, whether they're a cleaner or whether they're a CEO.
I think we would agree completely with what you say.
And Chris, it isn't just the money, is it? It's also the guidance.
Absolutely.
In fact, if anything, the guidance is more important than the money because they can work out roughly what money they're going to get. My local authority does a pretty good job of working out what money it's going to get.
Yeah,
it's
but
the guidance, it's the system they're going to have to work under is just as important.
Now that's completely true. But just on that energy shock question, I think there was a 4-point gap between what the inflation projection was and what it actually was as a result of the actions of foreign power. Now multiply that by 170 billion.
Well,
and you have a very large sum of money.
I hear that, Sir Chris, and I don't disagree with it. Hopefully that was a one-off, so hopefully we can't.
Well, for many reasons.
Hopefully we won't be able to use that as a reason for not giving them late allocations in future.
Yeah.
Clive Betts.
You described earlier this brave new world where at local level everyone works together, councils, NHS bodies, and delivers a joint strategy. How can that happen when the councils get their budget in December, or at least they get a pretty clear indication of what it's going to be, and their colleagues in the NHS are some months behind? You can't join up working relationships on that basis.
No, absolutely, and we do not aim to do allocations late. It comes back to when you can give out a realistic budget, which is partly dependent on the externalities. But your point is completely correct.
Right. So you want to aim to get the same date as the local authority settlement then?
Whether it's exactly the same day, we would aim before Christmas, right, as we have
and
said, partly for the reason that you say.
There are big external shocks, and there is such a thing as a supplementary budget, isn't there, on that sort of occasion? You don't always want to plan for something that may not happen.
No, that's absolutely true. And sorry, what I'm saying is, so I am agreeing with everyone that earlier is better. You do have to make a judgment about whether you're giving out a realistic number and whether that number is helpful, therefore. And the earlier you can do it, the better. And the closer you can get to being right, the better. As I say, giving people unrealistic numbers helps nobody.
No, okay. We'll leave that one there. We're almost at the end of the session, so Chris, you'll be glad to know.
No, I'll keep going.
I just want to come back onto something we have covered, and that is productivity, because it does seem to me that there is a great scope to raise the productivity. And if I could take you to paragraph 3.13 on page 41, and quote there, it says, "We think it is important for there to be a robust and widely accepted measure of health productivity." And we like measuring things in this committee. That means you've got to have proper baselines and proper data to be able to measure the productivity you're getting. It does seem to me that in both those areas, the NHS could do better. Would you like to comment?
Well, I would say that we think we can certainly continue to improve the measurement of productivity. I think relative to a lot of public services, actually, we do a pretty darn good job. In particular, we think we can do better with respect to community services, mental health services, where we have significantly improved data over recent years, still more to do. And we are in discussion with, for example, the Office of National Statistics and indeed York University, who are some of the leaders in this sort of academic field in the UK, as to how we can better capture the productivity that is derived from activity that leads to sort of prevented ill health, which is otherwise a thing which is really hard to measure because you're just measuring activity, you're not capturing the outcome. So we are in discussion with them as to how we can improve it. But, you know, it is a job.
Are we
of
likely to get
continuous
a clear definition anytime soon?
Well, we have a clear definition. The ONS publish data on a regular basis, and that, I think, is the sort of national statistic we rely on. We have measures which we use for sort of management purposes within the NHS, in particular for acute care. We have started to produce data for management purposes with respect to mental health services and community services in the second half of this year. Those give good baselines. But as I said, there are kind of methodological things we think we can do, which the ONS agree with us on, that means we can continue to improve it.
So I don't think one can ever be complacent about these matters. Now, you're clearly a man that's well over the top of the finances and the figures. Would you agree that there isn't a significant amount you can do to improve productivity from new technologies, from better collection of data and figures, but particularly AI, and therefore what are you doing about it within your organisation to make sure that you are completely up to date and are using and making best advantage of these new technologies?
Yeah, no, I mean, well, as discussed in one of the earlier answers, we absolutely think we can. I will say, though, that we think it is not just AI. It's actually just putting, as we were discussing earlier, like just modern technology into some of our providers who have lived, you know, on paper. And we still have some work to do to complete that programme. The aim is to do that over the next sort of 18 months. So just getting the basics right consistently across the NHS, I think, is step one.
Let me just give you a very simple example where I suspect that new technology could help you. There's a world of difference between 999 calls and 111 calls. And the 111 calls are a problem because the clinician goes into a situation, they don't have proper information, unlike the clinician that goes into a 999. Now, we're told that it's to do with the training of the call handlers. Now, new technology, that's a very simple fix. So why hasn't it been done? And what will you do to adopt new technologies in very simple situations like that?
Well, so, I mean, that's a really good example where new technology is not always a simple fix. So there are things which are simple. Well, they're not that simple, which is how do you create a really good single patient shared record. By the way, that is not a simple thing to do, but that is the plan that we are working out, and we have done the first stages of it with the shared care record, but that's the thing we can build upon, but that will take time because you need a consistent data infrastructure across the whole of the NHS, and you need to have sorted out all the information and governance issues. So what sounds simple, I will say, is not that simple, and we have a plan in progress.
And then clearly there are... Kelly, with great respect, I think you should look at what AI could do in that. So let me give you an simpler example.
And we are looking at what AI can do in a specific example of triaging 111.
Let me give you an even simpler example. You can't ask for an ambulance if you don't speak English. Google Translate would solve that in a second. So I would, in fact, can I just complete my question? Can I just ask you to give us a fairly full note of what you are doing to use new technologies in the health service? Would be really helpful. Thank you very much indeed, everybody. I'm sorry that the conversation got slightly heated, particularly from the chairman at times, but you can tell from the frustration, I think, from the committee that we are eager for you to improve the timeliness of what you do in the NHS. But we will be looking at these matters very simply, and an uncorrected version of the proceedings of this committee will be available in the next few days. Thereafter, we will produce a report with recommendations, and we will look forward with great interest to the Treasury Minute reply to our recommendations. So thank you all very, very much. This is a difficult subject. I know our questions sometimes make it look easy, but nevertheless, thank you for trying to answer our questions. All